There, my highly esteemed and honored viewers and listeners, welcome back to your channel of choice. Welcome to part 29 of our Pharmacotherapy MCQs series. My name is Dr. Nath Arwa, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to urge you to sit back and spare me part of your precious time as I share a few tips that will enhance your effectiveness in the line of duty. So our first question reads, a 46-year-old male patient presents to the clinic. He has a past medical history of hypertension and dyslipidemia. His calculated 10-year atherosclerotic cardiovascular disease risk stands at 8.2%. and he needs lipid lowering therapy. So my question to you is, which of the statements below represents the best goal reductions in low density cholesterol and preferred treatment options for this patient? Is it above 50% reduction in LDL cholesterol together with the initiation of 10 milligrams of Simvastatin at bedtime, or is it at least 30 to 50% reduction in LDL cholesterol levels and the initiation of high intensity statin, Atorvastatin, that is at a dose of 80 milligrams at bedtime, together with ezetimibe at a dose of 10 milligrams once daily? Or is it at least a 30 to 50% reduction in low density cholesterol levels and initiation of Atorvastatin at a dose of 2 milligrams at night? Or would it be equal to or over 70% reduction in LDL cholesterol levels together with the initiation of high intensity statin in the form of rosuvastatin at a dose of 40 milligrams at night? I'll give you 10 seconds to choose the correct answer. Settle for C. I would go for at least a 30 to 50% reduction in LDL cholesterol levels and initiate Atorvastatin at a dose of 2 milligrams at bedtime. Now, based on the information provided to us in this question, this patient is being evaluated for primary prevention since he hasn't had a reported vascular event or equivalent procedure, e.g. STEMI placement for the patients who must inevitably undergo PCI, for example. Now, given his atherosclerotic cardiovascular disease risk of 8.2% according to the data we've been given, that would put him in need of at least a 30 to 50% reduction in his LDL cholesterol, in my opinion, and that favors initiation of a moderate and not a high intensity, moderate intensity statin. So that automatically knocks off D, which is a high intensity statin, and B, which is also a high intensity Atorvastatin therapy. Now, Simvastatin isn't considered high intensity statin to reliably provide more than the 50% reductions of the LDL cholesterol for patients, so alternative A would not be suitable, especially with a dose of 10 milligrams per day. That is not even moderate intensity at all. As I've said, the rosuvastatin and the atorvastatin doses that have been quoted wouldn't be completely, those choices wouldn't be completely wrong, but they are considered high intensity statin therapies at those doses that we have been given. So they would be suitable when more than 50% reduction from baseline are needed but they would not apply well for this patient. And we would not go straight to initiating ezetimibe before we've tried a single statin. So the addition of ezetimibe at this stage to atorvastatin high intensity in alternative B wouldn't be called for or warranted at this stage. And just like to comment that patients in need of primary prevention against cardiovascular disease and those whose ASCVD risks are between 7.5 and less than 20% should be considered for moderate intensity statin therapy. That is why we would opt for pitavastatin at that dose of 2 milligrams at bedtime. Let's move to the next question. So our next question reads, JJM is a 70-year-old white male patient diagnosed with non-valvular atrial fibrillation. He has a past medical history of severe gastrointestinal bleeding. So my question to you is, which of the anticoagulants listed below would be the best option for stroke prevention in the case of JJM? Would it be rivaroxaban, edoxaban, dabigatran, or apixaban? I'll give you 10 seconds to select the best from that list of 4. In my opinion, D is the correct answer. Now, edoxaban, which is also called Savaysa, and rivaroxaban, which is also called Xarelto, are factor 10A inhibitors. They are only administered orally, for your information. Apixaban is a factor 10A inhibitor. Then dabigatran is a direct thrombin inhibitor. Those are administered twice daily, while the first two are administered once a day. Now, edoxaban and rivaroxaban and dabigatran had greater risks of gastrointestinal bleeding compared to warfarin in trials that were done, the Aristotle trial to be specific. Now, apixaban didn't have a significant increase in GI bleeding in the Aristotle trial. So that gives it superiority and an upper hand over the other 3 that exhibited risks. Let's move to the next question, which reads, which of the drugs listed below selectively inhibits the absorption of cholesterol in the intestine through its inhibition of the Niemann-Pick C1-like peptide, thereby resulting in a reduction in LDL cholesterol by about 20 to 25%? Is it gemfibrozil, atorvastatin, ezetimibe, or colesevelam? I'll give you 10 seconds to choose the correct answer. So ezetimibe it is. Ezetimibe is the first cholesterol absorption inhibitor that can reduce or primarily reduce LDL cholesterol either as monotherapy or in combination with statins or in combination with fenofibrate or in patients with homozygous familial hypercholesterolemia on either atorvastatin or simvastatin, and in patients with homozygous cytosterolemia. So it's a very versatile drug, if you ask me, and it has been especially useful in helping some patients with significant hyperlipidemia to get to their individualized LDL cholesterol goals when maximum statin doses have been tried without much success. Now, ezetimibe is able to inhibit cholesterol absorption by like around 54%, if I remember well from some forms of literature, which contributes to the net 18 to 20% reduction in LDL cholesterol seen in lipid profiles of patients as measured by our laboratories. Now, this improvement in LDL cholesterol is done without any compensatory increase in triglyceride concentrations, as is seen with the bile acid sequestrants, for example. That would happen with cholestyramine, to be specific, and even cholestyramine would do the same. And it also achieves this without an increase in risks of developing gallstones, as sometimes seen with the fibrates like fenofibrate, for example. So it's quite safe. Now, ezetimibe and its main metabolite, which is the glucuronide, prevent the absorption of cholesterol by directly binding to the transmembrane loop of NPC1L1, thereby inhibiting its ability to bind to the what we call the clathrin or AP2 that is required for its endocytosis. Now, since the NPC1L1 cholesterol complex can't be internalized, endocytosis cannot occur. Therefore, cholesterol can't then be brought into the enterocytes in the liver to form the initial ApoB48 containing chylomicrons that go into circulation. So that is the complex mechanism by which it helps lower the cholesterol. Now, just like to comment that atorvastatin is an HMG coenzyme A reductase inhibitor. It's a statin, to be specific. It's used mainly to decrease cholesterol synthesis, and it reduces LDL cholesterol. Gemfibrozil, on the other hand, is a fibrate, or we can call it a fibric acid derivative. It's used mainly to lower TGs, not LDL. And then cholestyramine is a bile acid sequestrant, just like cholestyramine, and it reduces the reabsorption of bile acids, which results in the liver having to use more of the circulating cholesterol to make more bile, because bile is very useful in digestion. And if its absorption is inhibited, then the liver has no option but to manufacture some. So it uses the cholesterol to do that, lowering the net cholesterol level. Just for your information. Let's move to the next question, which says, ASG, a 53-year-old male patient, presents to the accident and emergency and is diagnosed with a STEMI. He is rushed to the Cathlab within 20 minutes of arrival at your hospital, and 2 coronary drug eluting stents are successfully placed through PCI. Now, my question to you is, on which of the following treatments is he likely to be discharged? Will it be aspirin and ticagrelor for at least a year, or would it be aspirin for 6 months, or would it be aspirin and dabigatran for a year, or would it be aspirin co-formulated with dipyridamol for half a year? I'll give you 10 seconds to choose the correct answer. So A would be the correct answer in my opinion. Now, just like to emphasize that patients who undergo drug-eluting stent placement post-MI should be treated with aspirin plus a P2Y12 receptor inhibitor. And 3 examples that are common in our market are clopidogrel, prasugrel, and ticagrelor. And that should be therapy lasting at least 12 months. It may go beyond in some special circumstances. Now, aspirin and dipyridamol co-formulated are used in secondary stroke prevention, not post-MI. Then aspirin alongside dabigatran isn't indicated or used post-MI stent placement either. So that makes answer A the correct answer. Let's move to the next question. It reads, which of the following isn't an indication for Apixaban use? Is it DVT prophylaxis in hip and knee replacement surgeries, or is it to reduce risks of stroke in non-valvular atrial fibrillation, or is it acute coronary syndromes, or is it treatment of DVTs and pulmonary emboli? I'll give you 10 seconds to choose the correct answer. Out fellow there is acute coronary syndromes. So just like to emphasize that Apixaban is an oral factor 10A inhibitor that is indicated to reduce the risk of stroke and systemic embolism in patients with non-valvular atrial fibrillation. It can also be used for prophylaxis of DVT, which may lead to PE. So it can be used in prophylaxis of both in patients who have undergone hip and total knee replacement surgeries. It can also be used for the treatment, actual treatment of DVT and PE, and for the reduction in risk of recurrent DVT and PE following initial therapy. Now, it isn't used in treatment of ACS, however, and I would just like to say again that it is a major substrate of the CYP3A4 cytochrome enzyme system, and even the efflux membrane transporter, what we call the P-glycoprotein, and that makes it prone to very many clinically relevant drug-drug interactions. When you prescribe it, watch out for drug-drug interactions that may lead to either toxicity or having subtherapeutic serum levels. Just for your information. Let's move to the next question, please. Which reads, which of the following is the recommended dose of rivaroxaban, otherwise known as Xarelto, in patients for the management of deep venous thrombosis? Is it 15 milligrams twice daily with food for 7 days, followed by 20 milligrams once daily with food for a prolonged period, or is it initial parenteral anticoagulation for 5 to 10 days, followed by a dose of 60 milligrams once daily, or is it 15 milligrams twice daily with food for 21 days, followed by 20 milligrams once daily with food for a prolonged duration, or is it 10 milligrams twice daily for 7 days, followed by 5 milligrams twice daily for 5 days? I'll give you 10 seconds to choose the correct answer. In my opinion, C is the correct answer. I would go with the 15 milligrams twice daily for 3 weeks, and then switch to 20 milligrams once daily with food in both cases for a prolonged duration. Now, rivaroxaban is dosed at 15 milligrams BD with food for 3 weeks, then 20 milligrams OD, as I've said, with food for the treatment of DVT. And this has to do with the what we call the absolute bioavailability of rivaroxaban, which is dose dependent. Now, for 10 milligram doses, if you use the 10 milligram formulation, it is estimated that 80 to 100% of it is bioavailable. It is not grossly affected whether it's taken with or out of food, unlike the other two strengths of 15 and 20 milligrams. Now, for the 20 milligram dose, in a fasted state, the absolute bioavailability is approximately 66%, as quoted in literature. Now, co-administration with food increases this bioavailability, and mean area under the curve and Cmax increases by 39 and 76% respectively when you take it with food as compared to taking it in a fasted state. Now, for the Xarelto 15 and 20 milligram tablets, therefore, we insist you advise your patients to take them with food. And then the other points were just to confuse you. I'd just like to say that Apixaban is the one that is started at an initial, that is preceded by an initial parenteral anticoagulation, which should be done for 5 to 10 days, which is followed by a 60 milligram dose. And then it's Apixaban that is dosed at 10 milligrams BD for 7 days, followed by 5 milligrams BD. Those two are just meant to confuse you. Let's move to the next question, which reads, which of the medications listed below isn't able to provide anticoagulation to patients with antithrombin deficiency? Is it rivaroxaban? Is it fondaparinux? Is it agatroban? Or is it dabigatran? I'll give you 10 seconds to choose the correct answer. So fondaparinux or Arixtra it is, and I'll give you the explanation why. Now, unfractionated heparins and the low molecular weight heparins and parenteral factor 10A inhibitors, such as fondaparinux, all contain the needed pentasaccharide sequence required for proper binding to antithrombin, which then causes conformational changes in antithrombin, and that allows it to more effectively bind and inhibit the clotting factor 10A and factor 2A. Therefore, antithrombin must be present in circulation in order for any of these three medications to exert an anticoagulation effect. Now, rivaroxaban is an oral factor 10A inhibitor, which does not require the presence of antithrombin, unlike those ones I've mentioned earlier, for it to function optimally. And then dabigatran is also an oral thrombin inhibitor, and it doesn't need antithrombin to exert its pharmacologic effect. So that leaves us with Arixtra or fondaparinux as the odd fellow out. Let's move to the next question, which reads, at what creatinine clearance value or range should the use of rivaroxaban be avoided? Should it be above the 50 ml per minute mark, or should it be 30 to 50 ml per minute, or should it be 15 to 30 ml per minute, or should it be below the 15 ml per minute mark? I'll give you 10 seconds to choose the correct answer. So D, in my opinion, is the correct answer. Now, I'd just like to emphasize that rivaroxaban is an oral direct factor 10A inhibitor which exerts its pharmacologic effect without the need for antithrombin, as I've said earlier, to selectively and reversibly inhibit factor 10A, unlike fondaparinux, which requires the presence of antithrombin to inhibit factor 10A. Now, rivaroxaban is eliminated by the CYP2J2 and the CYP3A4 enzyme systems, and also it's affected by the P-glycoprotein system. Now, the elimination by the P-glycoprotein is the mechanism of elimination by the kidneys, to be specific, via tubular secretion into the urine filtrate. Now, approximately 66% of the drug is eliminated via this route. The other 28% is eliminated mainly in stool, in feces. Now, patients in what we call the Rocket AF trial who had creatinine clearance values below 15 were excluded, and thus the safety and efficacy in this population has not been established. So we don't want to risk accumulation leading to excessive bleeding. That's why I would discourage us from administering it to patients when their creatinine clearance falls below the 15 ml mark, just for your information. Let's move to the next question, which reads, a 68-year-old African American female was reviewed at the heart clinic at your hospital 72 hours ago to initiate pharmacologic management for newly diagnosed heart failure. Now, the echo showed a left ventricular ejection fraction of 25%. Really bad. She was initiated on fosinopril 10 milligrams once daily, metoprolol succinate 25 milligrams once daily, furosemide 20 milligrams orally once a day, and potassium supplementation 10 milliequivalents orally once a day. Now, she calls the clinic today, 3 days after initiation, with the chief complaint of fatigue and lethargy. And in her own words, she tells you she just doesn't feel like doing anything. The drugs are making her feel horrible. She also states that her daily walk around the block has become difficult and that she experiences dyspnea sooner than before her medications were initiated. And she says, I felt a lot better until you initiated me on these medications I'm currently taking. She's angry with you. So my question to you is, which of the drugs listed below is the most likely cause, rather, of the symptoms she is talking about? I'll give you 10 seconds to choose whether it is oral potassium supplementation, or metoprolol succinate, or fosinopril, or furosemide. So in my opinion, the correct answer is B. Metoprolol succinate it is. Now, when initiating therapy in heart failure patients, it's generally advised to initiate medications at lower doses and to increase or titrate them upwards as tolerated gradually. Don't start high with a bang. And this is especially true for beta blockers such as metoprolol, to avoid decompensated heart failure, given its negative inotropic and chronotropic properties. Patients can report symptoms similar to those that are reported in this particular case, like fatigue, lethargy, mild decompensation symptoms, when we initiate beta blockers and with each dose titration. Remember, when you increase the dose, this can also happen. They can begin to feel really bad. So you have to do it carefully and gradually. Now, in beta blocker studies in heart failure patients, initiation of beta blockers was started at low doses and were titrated no sooner than every couple of weeks. You can do it every 2 to 3 weeks, essentially to allow the body to readjust to the sympathetic nervous system blockade effects. That's where the problem lies. Now, this patient was started on a low dose of metoprolol succinate. It would be reasonable to either allow the patient to continue with the same dose and to see whether she adjusts to the beta blocker, or to consider decreasing the dose to 12.5 once daily, then reassessing and considering upward titration, but gradually. Now, she'll need to be closely monitored going forward, so that we look out for the compensation symptoms and further titrate the medication as needed. But it has to be done slowly so that she doesn't complain of those symptoms. Let's move to the next question. A.D.A. A 56-year-old African American male presents to the clinic. He has been having atrial fibrillation for the past 10 days, and he has a past medical history of STEMI. He's undergone CABG, and that was 3 years ago to be precise. He suffers from type 2 diabetes mellitus, and he tells you this is his first episode of atrial fibrillation. Now, his 1-month-old echo showed an ejection fraction of 50% and no left ventricular hypertrophy. He complains of occasional palpitations, which mostly occur when he exerts himself. Now you measure the heart rate and it reads 120, the blood pressure reads 130, systolic 85, diastolic. He's currently taking aspirin at a dose of 81 milligrams orally once daily, Metoprolol tartrate at a dose of 50 milligrams twice daily for the coronary artery disease. He also takes lisinopril at a dose of 10 milligrams once daily to manage his hypertension, and glipizide at a dose of 5 milligrams once daily to manage his type 2 diabetes mellitus. So my question to you is, which of the antiarrhythmics listed below isn't recommended to maintain sinus rhythm in the case of A.D.A? Is it amiodarone, propafenone, dofetilide, or dronedarone? I'll give you 10 seconds to choose the correct answer from that list. So propafenone it is. Now class 1C antiarrhythmics are contraindicated in patients with coronary artery disease or with non-structural heart disease due to their ability and the risk for new or worsening cardiac arrhythmias by, among other mechanisms, prolongation of QT and QRS intervals. Now we know that dofetilide is a class 3 agent, dronedarone is a miscellaneous agent, sotalol and amiodarone are class 3 agents, and catheter ablation is recommended for normal sinus rhythm control in patients with coronary artery disease. So the odd out figure there would be propafenone. It would cause more harm than good compared to the other three. So let's move to the next slide. The next question reads, JKB, a 49-year-old Hispanic male, presents to the hospital. He has a past medical history of asthma, gout, osteoarthritis, and your team is evaluating him for dyslipidemia. His family history includes father had osteoarthritis and suffered from chronic lower back pain, whilst the mother was hypertensive. He has been smoking half a packet daily for the past 5 years of cigarettes, that is. He denies drinking alcohol or using illicit drugs. He currently relieves pain by taking 1 to 2 tablets of paracetamol when in pain up to 4 times daily, and he inhales fluticasone, a puff of the 220 micrograms per dose twice daily for the management of his asthma. And selected vitals include a systolic blood pressure of 123, diastolic 73, a heart rate of 64, and the gentleman weighs 186 pounds. Part of his selected labs include total cholesterol of 205, HDL of 44, LDL of 124, TG of 183. You determine that he has no CHD risk equivalent, and his 10-year atherosclerotic cardiovascular disease risk score is 11%. My question to you is, which statement is true about his LDL cholesterol? Is it true that he needs a 15% reduction in LDL cholesterol? Is it true that his LDL goal should be below 70 milligrams per deciliter? Or is it true that he needs at least a 30% reduction in his LDL cholesterol? Or is it true that his LDL and CVD risks are good and no changes in LDL are needed at this time? I'll give you 10 seconds to choose the correct answer. So in my opinion, C is the correct answer. This gentleman needs at least a 30% reduction in his LDL cholesterol. Now, given his 10-year cardiovascular risk score, which is above 7.5, he is at high enough risk for heart attack, to be specific, in the next 10 years, that he would benefit from lowering of his LDL by between 30 and 49%. Now, a reduction in LDL by 15% isn't part of any recommendations. And then, with the exception of patients with diabetes mellitus, which this patient doesn't happen to suffer from, goal LDLs aren't needed here. So that's just for your information. Let's move to the next slide, which reads GGK. A 67-year-old Hispanic male presents to the hospital for STEMI. The cardiac team decides on medical management without coronary stenting, and aspirin is prescribed indefinitely. So my question to you is, for how long should GGK receive a P2Y12 receptor inhibitor, either clopidogrel or ticagrelor, alongside the aspirin? Should it be for 1 month, for 1.5 years, for a year, or for 6 months? I'll give you 10 seconds to choose the correct answer. So in my opinion, C is the correct answer. Now, dual antiplatelet therapy in patients with medical management who are not receiving any stent at all is recommended for at least 12 months, a year. And that's a class 1 recommendation that was originally released in 2011 in the Unstable Angina / STEMI update from that particular year, and it continues to be the recommendation in practice up to today. So the others are off the mark. Let's move to the next question, which reads, AJO presents to the cardiac clinic for review of his angina management. Now, bearing in mind that decreasing myocardial oxygen demand, MVO2, is critically important to minimizing angina episodes. Which strategy listed below would improve the angina by decreasing the MVO2? Would it be performing a cabbage procedure? Would it be infusing 2 units of packed red blood cells? Would it be prescribing a beta blocker? Or would it be providing home oxygen therapy? I'll give you 10 seconds to choose the correct answer. So in my opinion, prescribing a beta blocker would make the most sense. Now, management of angina is essentially about minimizing oxygen utilization, which we also call demand. And the 3 key components of oxygen demand are heart rate, contractility, and what we call intramyocardial wall tension. Now, of the listed options, prescribing a beta blocker is the only one that would affect the oxygen utilization by acting on the beta-1 receptor, to be specific, the beta-1 receptor in the heart, leading to a decrease in the heart rate, which we call a negative chronotropic effect. And it would also decrease contractility, which is negative inotropic effect. Now, the other options would target improving the amount of oxygen delivered to the myocardium, which is called supply. So that's just by the way. Let's move to the next question, which reads, which of the antiarrhythmic drugs listed below is generally avoided in heart failure patients due to its inability to prevent cardiac remodeling? Is it carvedilol, diltiazem, digoxin, or metoprolol? I'll give you 10 seconds to choose the correct answer. So diltiazem it is. Now both diltiazem and verapamil, which are non-dihydropyridine calcium channel blockers, don't inhibit remodeling of the cardiac muscles and thus don't have a benefit in the management of chronic heart failure, unlike the beta blockers. Now both carvedilol and metoprolol, succinate to be specific, are known to inhibit cardiac remodeling and also provide mortality benefit in heart failure patients. Now digoxin, on the other hand, can be used in heart failure, but it doesn't have an impact on cardiac remodeling. So that's just by the way. Let's move to the next slide, please. Next question reads, which of the 4 vasodilators listed below, utilized in the acute management of hypotension, mainly stimulates the alpha-1 but also stimulates beta-1 receptors to a small extent? Is it phenylephrine? Is it epinephrine? Is it norepinephrine or vasopressin? I'll give you 10 seconds to choose the correct answer. So norepi it is. Now norepinephrine primarily stimulates alpha-1 receptors to increase the afterload or systemic vascular resistance, what we abbreviate as SVR in literature. And that happens due to its vasoconstrictive properties on the arterial vasculature. It can also to some extent stimulate beta-1 receptors in the heart, leading to a slight increase in the pulse rate. Now epinephrine, alternative B, is a vasoconstrictor that is thought to have equal stimulatory activities on alpha-1 and beta-1 receptors. Phenylephrine, on the other side, is a vasopressor with pure alpha-1 agonist activity and is primarily used for rapid increase in BP. When we need to up the blood pressure rapidly, it is very handy in critical care. Vasopressin is a vasopressor that is known to stimulate the V1 receptors and can cause vasoconstriction and increase the systemic vascular resistance. Now norepi should only be administered as an IV infusion via a large bore needle. And that should be a large bore, well placed IV or a central line, and via a programmable infusion pump, just to avoid overdosing. For your information, let's move to the next question, which reads, PAM, a 64-year-old Caucasian man weighing 125 kilos presents to the accident and emergency with a chief complaint of chest pain, which he claims had a sudden onset and is still persisting 30 minutes down the line. He tells you he's never experienced such pain before. It's overwhelmingly painful. He has a past medical history of hypertension, type 2 diabetes mellitus, and he suffers from mild asthma. Currently, he takes 81 milligrams of aspirin once daily, 20 milligrams of lisinopril orally once a day. He takes 500 milligrams of metformin twice daily, after breakfast and after dinner, and he administers 2 puffs of salbutamol up to 4 times daily when necessary, and he is compliant according to him, according to what he tells you, with all his medications. He tells you he drinks socially and he has smoked half a packet per day for the past 25 years. An ECG is done at the A&E and it shows an ST change of 0.8 mm, and his troponins are elevated, they are abnormal according to the results reported by your lab. Now, based on PAM's medical history and the clinical presentation, determine his STEMI risk score, and based on this score, stratify his overall mortality risk. Do you consider him being of medium risk, low risk, or do you think not enough information has been provided to calculate the STEMI risk score? Or is he high risk in your opinion? I'll give you 10 seconds to choose the correct answer. So in my opinion, he is or belongs to the medium risk category. Now his STEMI risk score is 4, resulting in a medium risk. Using the STEMI risk score, 1 point is assigned for each of the 4 medical history and 3 clinical findings stated up in the text above. The total points are calculated and patients are assigned a risk for composite end point of death or of MI or urgent need for revascularization within the next 14 days. So when the score falls between 0 and 1, there's a 4.7% risk. When it falls at 2, it's an 8.3% risk. 3 corresponds to 13.2%, 4 corresponds to 19.9%, 5 corresponds to 26.2%, and 6 to 7 correspond to 40.9%. Now, STEMI risk scores are used for unstable angina or STEMI patients when we want to prognosticate and make a therapeutic decision. It can guide you on how to intervene and how urgently to do so, just for your information. But I would consider this patient a medium risk patient. Let's move to the next slide, please. So our next question reads, you are evaluating AWG who is being initiated on Atorvastatin therapy for dyslipidemia. Now, while compiling a comprehensive medication list after a thoroughly done medication reconciliation, you are considering when he should report for a follow-up appointment. Now, knowing it will take 4 to 6 weeks for his lipid panel to reflect changes from the Atorvastatin you intend to initiate today, what would be the recommendation for the monitoring of liver enzymes? Would you recommend they be monitored at baseline and then every 3 to 6 months thereafter? Or would you consider doing it at baseline and then every 2 months for the first year, then periodically thereafter? Or would you consider doing it at baseline and at least once yearly thereafter? Or would you do it at baseline and then as clinically indicated thereafter? I'll give you 10 seconds to choose the correct answer. Personally, I would do it at baseline and then as clinically indicated, and I'll explain why. Now, in 2012, the FDA issued a drug safety communication revising the monitoring of liver enzymes during statin therapy. Now, they recommended monitoring at baseline and then as clinically indicated thereafter. They concluded that serious liver injury with statins is rare and is also unpredictable in individual patients, and that routine periodic monitoring of liver enzymes doesn't appear to be effective in detecting or preventing serious liver injury. So that explains why it should be done at baseline. Then when the practitioner notices something is amiss, it would be in order to repeat another liver function test. Let's move to the next slide, please. So ASV, a 59-year-old Hispanic female, presents to the hospital for the management of chronic stable angina with a past medical history of hypertension, moderate to persistent asthma, dyslipidemia, coronary artery disease. She underwent an MI 6 months ago where a PCI was done and drug-eluting stent was placed in the mid-left anterior descending artery, what we abbreviate as LAD. Now, in today's visit or appointment, her chief complaint is 2 to 3 angina episodes weekly, and this began after she stopped her carvedilol due to the worsening of her asthma symptoms. Now, she's compliant with the other medications apart from skipping the carvedilol, and the selected vitals include the initial BP readings, which were systolic 132, diastolic 78, and the heart rate then was 80. Now, in today's visit, the systolic blood pressure is 136, diastolic is 82, the heart rate remains constant, and she currently inhales 1 to 2 puffs of salbutamol every 4 to 6 hours when necessary. She prophylactically takes 81 milligrams of aspirin once daily, alongside 75 milligrams of clopidogrel once a day. Inhales fluticasone 220 micrograms per puff at a dose of 2 puffs twice daily. She also takes fosinopril 20 milligrams once a day, alongside isosorbide monodinitrate 20 milligrams thrice daily, and the timings are specific. At 6 a.m., at noon, and at 6 p.m. And then she also takes inhales salmeterol 1 puff twice daily, and takes 10 milligrams of Atorvastatin at bedtime at night. Selected labs include sodium levels of 140, potassium of 5.1 milliequivalents per liter, BUN of 14, serum creatinine of 1.2, AST of 25, LT of 31, total cholesterol of 148, HDL of 56, LDL of 65, and a TG of 134. Assuming no contraindications exist, which of the therapeutic options listed below would be the most appropriate to address ASV's continuing angina episodes? Would you increase the rosuvastatin dose to 20 milligrams at bedtime? Or would you add verapamil extended release at a dose of 180 milligrams once daily? Or would you consider upping the fosinopril dose and up to 40 milligrams once a day? Or would you change the isosorbide dinitrate to isosorbide mononitrate SA 30 milligrams once daily? I'll give you 10 seconds to choose the correct answer. In my opinion, verapamil is the missing link. I would add verapamil extended release at a dose of 180 milligrams once daily. Now, in angina patients who are intolerant of beta blockers, the use of a calcium channel blocker is indicated as per guidelines, assuming no contraindications to the calcium channel blocker exists. Now, given this angina episode started after stopping her carvedilol, her heart rate isn't at the desired dose. Remember, we recommend the upper 50s that is 55, to the lower 60s, around 60 beats per minute, and her blood pressure still remains on the higher end of normal. If you are using the J and C criteria, it remains above goal. If you are using the AHA, IHD hypertension guidelines as well. So because of all that, in my opinion, the use of a calcium channel blocker is the most appropriate choice at this stage, and specifically a non-dihydropyridine calcium channel blocker such as verapamil or diltiazem for both the BP and the rate lowering effects, and that those would be considered preferable to the dihydropyridine calcium channel blockers like amlodipine or felodipine, which would provide selective BP lowering with a risk of rebound tachycardia, and that may worsen this patient's angina. Now, while increasing the fosinopril dose would help with the BP, if you look at her potassium levels, they are already high. They are around 5.1. So adding an ACE inhibitor would only worsen things, would lead to a worse of hyperkalemia that could cause an arrhythmia. Yeah, it's already on the higher end of normal, so I would not opt for an ACE inhibitor like fosinopril, or I would not opt to increase the dose. And then changing isosobite dinitrite, TDS, to mononitrite OD would be beneficial from a compliance standpoint. But we know that the patient is compliant, so that would not add value, it would not make much of a difference. And then changing the two nitrates, swapping them, doesn't increase the total amount of nitrate delivered. Actually, it essentially reduces the amount, which may be counterproductive. And then increasing the rosuvastatin dose isn't indicated, since her lipid panel reveals excellent control, in my opinion. So that brings us to the end of part 29 of our pharmacotherapy MCQ series. I highly appreciate the fact that you sacrifice time and viewed and listened to this video. I highly appreciate your continued support, and I would like to urge you to give it a thumbs up and to like it. And if this video benefited you in any way, I would like to urge you to subscribe to my YouTube channel. I promise you from the bottom of my heart that the best is yet to come. I look forward to further interactions with you in the next video, which will be part 30 of our series. Thank you very much for listening and for watching and for always being there for me.